Hi all, welcome to Raaonline. In this topic we will be dealing about anesthetic management of congenital disease. What happens when you give various anesthetic agent in a child with congenital heart disease. Now coming to induction and maintenance, here you have to understand each disease process anatomically as well as pathophysiologically. That is very important. This understanding helps us to have a working knowledge of various anesthetic and pharmacological intervention on the patient condition. This is very important. For example, if there is a large left to right shunt, what will happen if you give inhalational agents and intravenous agent? If you give low dose, what will happen? If you give high dose, what will happen? You should have a working knowledge. Maybe you may not be predicted accurately, but you should have a working knowledge of what can happen if you give high or low level of anesthetic agent. Degree of cardiac function, whether the child cardiorespiratory status is normal, whether the heart function is moderately affected or is in the normal stage. The measurement of cardiac defect, for example, the size of ASD, which is restrictive or non-restrictive, that is very important. The degree of sedation provided by pre-medication, which can alter your induction in the perioperative period. If you have given deep pre-medication in the preoperative period, your anesthetic requirement during induction might come down. And another important thing is the presence of indwelling catheter, whether the anesthetic agent can be induced in the preoperative period or in the intraoperative period with the inhalation agent can depend upon an indwelling catheter. These are all the various factors which can alter your induction and maintenance. In children with good cardiac reserve, that means the child is adequately compensated, the induction technique can vary in well-monitored patient. The titration of the anesthetic for induction of anesthesia is more important than the specific induction technique. That means it doesn't mean it is inhalational or induction, but the titration of the required amount of drug for that particular disease is very important. A broad spectrum of anesthetic induction includes sevoflurane, isoflurane, nitrous oxide, intravenous or intramuscular ketamine, intravenous propofol, fentanyl and midazolam. Usually these are the various drugs which are used in combination. Ketamine is often used as an induction agent in cyanotic congenital heart disease. This is because it increases the systemic vascular resistance and reduces the magnitude of right to left shunting, and it also increases the cardiac output. Administration of ketamine can be done intravenous or intramuscular. The problem with intramuscular is it might result in pain, agitation and subsequent arterial desaturation. Coming to inhalational inductions are generally well tolerated by most kids. Inhalational induction with sevoflurane can be safely performed even in cyanotic kid, those with tetralogy of Fallot. In this patient who are at risk for right to left shunting and systemic desaturation, oxygenation can be still maintained if you have a good airway and ventilation despite reduction in systemic vascular resistance. Your sevoflurane is going to reduce your systemic vascular resistance, so there is going to be lot of right to left shunting, so desaturation will happen. But if you maintain the airway properly and adequately ventilate the patient, that desaturation can be easily countered.